So let's get recorded. Week 7. Now, this is actually a good time to start your projects if you haven't already. I know one person is already done and I'm extremely happy that they are done. So again, you submit that to me in pieces. I can review it, grade it, tell you what you need to improve, and you can get perfect grades. This is 6% of your objective grade. It's more than all of the Sims is actually all the Sims, and that is equal. And NCLEX is more than that in percentage. It's a big chunk. So send it in pieces, and I will help you to understand. And Dr. Brown knows I do this because many of you want to go on in your degrees and you want to go get your bachelor's and your master's. You're going to have to write papers. You're going to have to know APA. You're going to have to know how to submit projects. So I'm here to try to get you so that you do them even better, okay? Imani, are you there? I'm going to have to remove you. And Megan, please come on. If anybody has their cell phones, could you text them, let them know they need to come on? And just having your camera there on is not meaning
I'll call Imani.
Appreciate that, Aisha. Anybody know Megan?
She said, I called her a minute ago and she said she messaged you.
Oh, yes, she did. But not about that. I'll give her a couple more minutes and then I'll go back and I'll check on her.
Imani said she's coming. She's in the restroom.
Okay, I appreciate that. All right, let's go ahead. Let's do it. Go ahead. Somebody else? Yes?
Yes, I'm sorry. I have another question. If I recall, you said that we could do a PowerPoint as well, right? Like instead of the 250, the minimum of the 250?
No, you do the 250 words. You do the assessment form that is on your modules, and you do a teaching, which could be a PowerPoint or a brochure, or maybe just a poster board, it's called. You put pictures, they're great. It tells a lot of words about it. And that the teaching is you could teach nurses, patients, or children. So
okay,
those
so
are all, yes. And there's 3 sections of it. Okay. They're all 33% of it.
Okay.
This week you have a Sims that's due, Eduardo Rios Hernandez, and discussion question 5. I'm just doing discussion questions 4 and scoring them. Got a little behind, but they will be done by the middle of the week. And remember, go back and read what I put in those discussion questions. One question on Downs, the answer was in the discussion question on the post I put there, those comments. I put these nice little comments and tell you a little bit more. So go back and look at them because you'll see something in there regarding that Downs on that discussion question. So let's go ahead. Let's do the Kahoots. It is, a lot of stuff today. It's cerebral and endocrine. I mean, how do I do this on a Kahoots? Well, I'm going to show you how to think and how to read words and what do those words mean. I think we tend to think too much and we have to just go back to what do you know? The simplicity of what do we know? Because you can figure a lot of things out, just logical. I mean, we all know how to arrange our schedules and get everything done. And you guys are so good about getting things done and communicating. Well, that's logical, isn't it? That's critical thinking, getting what you need done. So same thing with the information that you're getting. And I know it's hard to think that way. Okay, let's just get going. So week 7. Growth hormone is administered by what root? Well, the pituitary gland submits growth hormone, and growth hormone is needed to make children get taller and get bigger. This is why we do heights and weights every visit. Well, some children are very, very small, And parents want them to be taller. And it's not because the parents are short themselves. It's just the child doesn't have enough growth hormone. It is a big obligation by the child and the parent. It is usually daily subcutaneous injections or weekly, depending on the physician, depending on medicines. So it's just like giving insulin, sub-Q injections. But we've seen really good response from it. And you take it until you stop growing 1 inch or less a year. Then they stop it, usually about that pre-adolescent growth time. Highest priority for a patient diagnosed with syndrome of inappropriate antidiuretic hormone. Let's pull the word apart. Inappropriate, okay, antidiuretic against urinating hormone. Simple. What would you see if anti-urinating was happening? You see how easy that big word, that big thing is. SIADH. So you're not urinating. You're not getting enough of this anti-diuretic. It's too much. So we're just sucking it in and keeping it. Daily weights, intake, output is the most important thing. Good. You're listening. Which of the following are signs and symptoms of an inappropriate antidiuretic hormone? Well, it's against urinating. We know we have to do intake, output, and daily weights. What are we looking for? What happens if you are anti-urinating, right? You're not urinating. It's decreased urine output, right? And what would you see? You'd see edema, swelling, probably around the eyes would be swollen. You'll be gaining weight. Your intake will be more than your output. And then maybe it gets even into your lungs because of so much fluid. What is important to cover when teaching the family about polypropyl? This is also called PTU. It's for the thyroid gland. We give this to children and adults, and we use it for too much thyroid. It suppresses it so that you're not getting too much. Now, when you give it, you need to know that this is something that it decreases the thyroid being put out. It also causes leukopenia. So any sort of fevers, sore throats could be a side effect from it. So what do you see when you have too much thyroid hormone? This is everything's up, up, up. Heart rate, blood pressure's up. You could get tightness in the chest and dizziness. It's like thyroid storms. It's too much. So we use this medication before we go into ablations and surgery to remove thyroids. A multi-select. An initial sign of diabetes insipidus. This is opposite of SIADH. So SIADH, inappropriate anti-diuretic hormone. Well, this is too much diuretic hormone. What do you see? This is when you drink too much and you urinate a lot. Now, when you add polyphagia, that's diabetes, okay? But diabetes insipidus is from the pituitary gland, and it secretes too much hormone. You urinate a lot. So you would see polyuria, polydipsia. In the infant, they will cry. They're hungry, hungry, hungry. But when you give them a bottle of water, it satisfies them. So then you have the clue. Let's look at these hormones from the pituitary gland. Measures, intake, output, daily weights, fluid balance. Those three things always think about. A multi-select. What are the clinical manifestations of juvenile hypothyroidism? Well, adult hypothyroidism and juvenile are the same except for one thing. So you're going to see the dry skin, you're going to see constipation, you're going to see weight gain because everything slows down. But the one thing that affects is growth. Again, why do we do height and weight every visit? We're looking for the growth hormone, we're looking for thyroids, we're looking at clues and hints something's going on. And that's why those things are so important. A child has a simple febrile seizure. What education would you provide to the parents? Now, febrile seizures are the most common of all seizures in children. And it's not that they have a fever, it's they went from no fever to a fever extremely quickly. And the brain goes, bzz, you can't handle that change, and it has a seizure. And they are big seizures. So, always, any seizure, we need to keep safety, right? Nothing in the mouth. We can't do anything like that, but turn them on their side in case they vomit. Remove anything that's sharp that could hurt them in the bed. Document it, take the time of it so that you know what's going on. Call for help if it doesn't stop, right? And then when they're, protect from injury. And that's what we do with seizures, whether it be febrile or not. I mean, my daughter-in-law used to carry around a thermometer and every antipyretic. My first grandson had febrile seizures, none of the others. What type of seizure is when the body is jerking, you're foaming at the mouth, and the child is rendered unconscious? Now, I'm telling you, it's not febrile. In febrile, they're not that foaming, jerking. This is the one that's probably, the most severe of all, especially if they're more than one a day or very frequent. And these are your tonic-clonics. Again, how do you treat it? Same way. Turn them on their side. I'd have suction in case they vomit to keep it away from their mouth so they don't inhale it, right? But protect from injury, pad the side rails, call for help if it continues, and document. What notable sign may indicate increased intracranial pressure in an infant? Now, infants can't tell you their head hurts, right? But there's some things they can do that gives you a clue. I mean, one of them might be a bulging fontanelle at all times, not just when crying, all the time. That's showing you maybe hydrocephalus, something's going on there. But infants that are neuro or have that pressure have this high-pitched cry that is different from a baby cry. It's like nails on a chalkboard. It really, you can walk into a room of crying babies and go, that one, something's going on with their head, something, if we didn't know already, because it's very high pitched, very distinct that we could tell. All of the following increase intracranial pressure except what? If we're taking care of a child who has a brain injury, we need to know what we can do and can't do, right? Or what we have to be careful with. And that's what this question is all about. They can have an elevated heart rate and it doesn't bother them. Now, suctioning, coughing, fluid, all of those things will increase pressure. You put too much fluid, too much intake, not enough output, the fluid will go to the brain and it will cause more pressure and then cause more problems. What findings can alert you to a head injury getting worse? Now, working in the ER, I used to see all sorts of sports injury coming in where they got hit in the head with a knee and they were knocked out and they were told to go to the ER and get help. What would this child look like? Well, they would have what we call a change in orientation. And it could be as simple as, so was I safe? Did they win the game? Is daddy coming? Is daddy coming? And repeating it over and over again. That's that change in orientation. It can get to the point of being coma, but usually that's the first thing that we see. A multi. What does it mean when you see a fixed and dilated pupil after a head injury? You know, I used to be primary nurse on the trauma team. They loved me to run them because I was such the calm and cool person. And you get a child in who's fallen off second story balcony, which I've seen more than once. First thing we do is look at the pupils. And if they're fixed and dilated, that child is in serious trouble. We need to do something to decrease the pressure in that brain, or after 5 minutes, it's a brain stem injury. And that child, you cannot bring back from that. Okay. Fixed and dilated is the worst you can see after some sort of head injury. What medication may be used for a child with cerebral edema due to a fall? Well, edema is fluid. You need a diuretic. Now, it is the one for the head, not just the normal one we use for everything. Remember, there are a couple different types of them. We have aldactone, we have furosemide, we have mannitol. Mannitol specifically for the brain. It could be used in renal failure and some toxic things, but heads, it works beautifully. Ray's syndrome, what do you know about it? Ray's syndrome is due to taking aspirin, and there's a metabolic disorder, and it is in children. This is why we tell our parents never give your child an aspirin unless they have Kawasaki disease. That's the only time we give it, because that's to prevent clots because of the microembolus of that vascular type of inflammation. So Ray's syndrome is because of aspirin. That's why we don't give it, and that's what we should teach. Febrile seizures usually occur in children of what age? And it's 6 months. Some books say 3 months, but 6 months to about 6 years. Thankfully, they grow out of it. They don't continue with it for life. Many times parents will say, "Oh my God, my child had a seizure. Does he have epilepsy?" One time, one occurrence does not mean epilepsy. When you talk about epilepsy, it's more than one a day and frequency of them, okay? And then it would be investigated. But febrile seizures, thank God they grow out of them, like my grandson. Childhood hypopituitarism results in which condition? Remember, one side is fluid balance and the other side is all about growth. So that's the two lobes. The anterior is growth, the posterior pituitary is fluid balance. So hypo is less than, so it is pituitary dwarfism. If I said hyperpituitarism, they would be too big, and they could get to be 7, 8 feet tall. Usually hyper is due to a pituitary tumor. How would you describe precocious puberty? Again, it's something to do with hormones and through puberty. And this is those girls who could start puberty at age 6, or boys getting, facial hair early. I mean, it can happen in boys and girls. We usually think about only girls with this, but we can stop that with medication called Lupron and wait till when they're supposed to go through puberty. Can you imagine a little 6-year-old girl with breasts and a bra? Can you imagine what those other children do? Or a little boy with a beard? Because it can get that severe. A multi-select. What lab values are important to monitor with a child with congenital hypothyroidism? What labs are you going to draw? Which ones are important? One of the things that we know about hypothyroidism, this is one of those conditions that at birth, if they don't move their bowels within the first 2 days, this is another one of the things that they are going to be testing for. Cystic fibrosis is one, and hypothyroidism. And next week, I'm going to show you another thing they'll test for, but it's T3, T4, TSH. Remember, growth hormone is pituitary. Cortisol is adrenal, okay? You got to know where the hormones come from. How can you monitor a child with hypo or hyperthyroidism? What have I been saying all along? It's all about measuring. Remember, it has to do with growth. Hypo have to do with the growth in children. That's the difference between adults and children. It's the growth. Too tall, too short. And that's why every visit, there's a height and a weight when we are dealing with children in the ER or a doctor's office. Don't matter. What acid-base alteration would you see in a diabetic child with Kussmaul respirations? Well, what is Kussmaul respiration? That's diabetes type 1. And the body is trying to compensate with these Kussmaul respirations. They tend to be slow and rapid because they're trying to blow off the acid. So it is respiratory alkalosis because the body is in the opposite, acidosis metabolic, okay? So they are usually about 4 questions on acid base on the HESI. So you will see me adding these acid base questions now. And as we go on, I'm going to explain it some more. A multi. What would a child with Cushing syndrome look like? Well, Cushing syndrome is adrenal. Adrenal gland, or it could be taking steroids because cortisol is all about the adrenals. And Cushing's is too much adrenal hormone, or taking prednisone way too much. And this is a child, big round moon face. You're going to see a pendulous abdomen, ruddy, red ruddy. It means these red, like almost beefy looking cheeks you'll see on them. You're going to see hair growth, little children with on their chins, not normal. And these kids are very conscious because they're big all over the place. How do you correct Cushing syndrome if it's due to prednisone? Well, we taper it off, right? Slowly, so we don't go into a crisis. A multi. You walk into a child's room with a fever of 104.6. You see them having a seizure. What are you going to do? So again, very good. You're going to check the bed for whatever safety, right? Side rails up, pat them if you can, turn them to the side, have suction available in case they vomit, just to keep that area clean. Not for their mouth, but for the area so they don't inhale their own vomit, because many times they do vomit. An autoimmune disease of the thyroid gland. My daughter-in-law has this. And this is autoimmune, cannot be corrected with surgery. You do not touch that thyroid. It is thyroid replacements for life. Usually it's in that pre-adolescent, older school age and adolescent area, and it's called Hashimoto's, okay? The big thing about this one, it's the replacements you have to take, and you cannot do surgery to correct this. The body's just attacking its own thyroid gland. Addison disease is opposite of Cushing's disease, right? Another adrenal. So we've talked hyperthyroid, hypothyroid. We've talked about too much growth, too little growth, too much fluid, not enough fluid. Now we're talking about the adrenal, too much, too little. So it's a decreased secretion of cortisol and aldosterone. One of the things with Addison disease is these children, stress will affect them. And at that time when they're going through stress, they might need extra cortisol or extra aldosterone to keep up with the stress that they are having. Because adrenals do what? They secrete cortisol and aldosterone. A multi. A ventricular peritoneal shunt. What is that? Well, you've got a picture up there, and you've got a catheter in that fourth ventricle, and that's a brain. This is used when there's too much fluid on the brain and the brain cannot drain it normally. If you do not drain it, the head just gets bigger. On an infant, you will see that big round fontanelle, and it gets to the point where you see scalp veins even popping out of their head. How do we as nurses monitor this? Well, it's a tube that goes from the brain behind the ear, and there's a little ball there. We never, ever, ever touch that. That's only for the neurosurgeon. And then the catheter goes into the peritoneum, and it slowly will drain fluid. So measure the head, making sure it's not getting bigger, the catheter don't work, and then you're going to measure the abdomen, making sure that too much isn't going there also. And if they're an infant, we're going to be looking at that fontanelle. A common sign of Graves' disease includes blank or protrusion of the eyes. This is hyperthyroidism. Too much thyroid hormones being produced. I had a girlfriend who had eyes who looked like that, who didn't have Graves' disease. And everybody always asked her. It's just the way she was. It is called exophthalmos. Have you seen the commercial on TV with a lady with the glasses that she's putting drops in, and after a while they have gotten it better? Well, that is Graves' disease. That is called exophthalmos. A multi-select. Hypoparathyroidism has the symptoms of tetanic muscle contractions and what? Now, has nothing to do with the thyroid. It's connected to it in that same area, but it has nothing to do with the thyroid gland. When you think of muscles, what do you think about? What helps muscles, right? And that's calcium. Whenever you talk about muscle contraction, tetany, too much, too little, hypotonia, think about calcium and magnesium also. But with hypoparathyroidism, it regulates calcium. So you see hypo, there's not enough muscle contraction, it's going to be weak or just flaccid and laying there, okay? So hypoparathyroid is calcium. A multi. What are signs of hyperparathyroidism? Well, I said hypo is not enough calcium. Hyper must be too much calcium. What would you see? And it gets to the point they're nauseous, they're vomiting, they're confused, their muscles are going crazy, and then the paresthesia, they can't even move them at this point. So that's hyperparathyroidism. What does the parathyroid hormone do? And it's all about regulating calcium, okay? The parathyroid is not the growth hormone. That's in the pituitary gland. Which of the following might be a cause of an adrenal crisis or Addisonian crisis? So one of the things about, having Cushing's disease, and I first started with rheumatoid arthritis, they were giving me way too much steroids in the day. And I actually got to Cushing's. I didn't eat much and I was getting bigger and bigger. And one of the things that I was so diligent and careful was slowly getting off those steroids because you will go into the Addisonian crisis and it's a very dangerous thing. Your heart doesn't know what to do, your body doesn't know what to do, and it needs steroids in order to stop that Addisonian crisis. A multi-select. Cardinal sign of diabetes insipidus. Told you earlier. Remember, it's opposite of the syndrome of inappropriate antidiuretic hormone. It's also called DI. Is one of the initials they use for it. Cardinal sign, what do you see? Polyuria, polydipsia. As I said before, polyphagia is with diabetes. Diabetes insipidus is too much urine coming out, so it is not decreased. Remember, diabetes insipidus is two P's. If you look at insipidus, there's two P's. That's what it is, two P's. A multi. Congenital hypoplasia parents' teaching should include this is when the adrenal gland is not producing enough hormone. And these children will be on lifelong cortisol and aldosterone replacement. But also, it does cause these children to be born with sometimes two different sexes. I have seen a penis with a vagina, and I have seen a clitoris with a penis. It's just crazy. They don't know. So, what did we do? And I didn't understand it when I first saw this child. I was actually just started in the newborn ICU, first time in pediatrics. And what they did was they went and found out what body parts this child had. They did hormone testing, found out what the child was more tended towards, and then they did gender assignment and they did the surgeries to go along with it. This is why sometimes there's confusion, like some of the TV shows out there, right? There's some confusion about are they a boy, are they a girl? They will never have children. They are infertile, okay? And the hard part, I think, is the parents dealing with a child that they don't know if it's a boy or a girl. So you had a baby, what is it? Can you imagine? These parents need support. What causes type 1 diabetes? Too many candy bars. So what happens with diabetes is the pancreas is attacked. It's an autoimmune thing, and it doesn't produce insulin, right? So type 1 diabetes, what is it all about? Well, these children come in and they could be very young and they will have recent weight loss. They'll be urinating. They will be drinking a lot and they're eating a lot. And why are they eating a lot? Well, sugar is not metabolized and not made into something the body can use. So the body's hungry. So what does the body do? It says, okay, I don't have sugar. I'm hungry. Let me go eat protein and fat. Byproducts are ketones. And that's as simple as what diabetes type 1 is. Children, the young ones with diabetes, are always type 1. They never turn to type 2. The only child would be an adolescent who was a type 2. Okay? But the younger kids are always type 1. Which statement about a pheochromocytoma is correct? This is a tumor on the adrenal gland. So the thing about this tumor is all of a sudden heart rate goes up, blood pressure gets up, they get dizzy, tightness in the chest, and then it goes away. And they're doing all this cardiac workup because that's the symptoms, right? Well, finally we figure out it's on the adrenal gland, and it's what we call a catecholamine producing. Everything up, 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 up. So one of the things as nurses we need to be monitoring the vital signs when these patients are saying, I'm dizzy, my chest hurts, and you feel their pulse, and their pulse is way, way up. Oops, how did I do that? Excuse me. Forgive me. I was trying to do something else. So anyway, catecholamine, everything up, heart rate up, blood pressure up. So multi-select. Which action should the nurse implement in the care of a patient with a pheochromocytoma? So they're telling you you have a child who's admitted with a pheochromocytoma. Well, what are you going to do? What is your care? What do you need to look for? How do you assess? And that again is looking for those things that go up, 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 which is the blood pressure and the heart rate. We don't look at what weight gain has nothing to do with fluid balance, has nothing to do with sugar. This chapter is, you have to keep the adrenal, pituitary, thyroid, keep them separate. They do get mixed up. A multi-select. Nursing care of the unconscious child include what? Children can be unconscious for many reasons, but it could be like that one little girl who fell off the second floor balcony and fell and had a massive head injury, and they were unconscious. I mean, eventually she woke up, but how do you take care of them? Well, neuroscience is always there. Also, vital signs, it can tell you what's going on. Elevated could be pain, medicate them at that point. And of course, checking for temperature because that can show you, elevated things are due to that. And of course, anyone with anything in a head, strict INO and daily weights if we can. What might you suspect if a child feels jittery, sweaty, and dizzy? And this is probably hypoglycemic. Children with diabetes type 1 do really well. They should be carrying around sugar pills or something that they can eat quick if they start feeling like that. If they're playing sports, they should be checking their blood sugars before they go out in the field, and then keep well hydrated. They can live perfectly normal lives, but they need to know what's going on. A lot of them get the insulin pump. And when they get that pump is when they can handle it and manage it themselves, and they can bolus themselves, when their blood sugar goes up. So they've got one needle in them and they don't have to keep sticking themselves with coverages, which is pretty cool, I think, actually, for kids. So symptoms of diabetic ketoacidosis are what? What do you see? Have a child come into the ER and they're in DKA. What would I see? What would it look like? What I'm going to be looking for, right? These children come in pale. They're a little bit confused. They really are just like exhausted. These children are, smell of their breath smells like you put a peach in a container closed in the refrigerator and forgot about it for 2 months. You take it out and you open up that container and it's a rotten, smelly, fruity peach. That's what their breath smells like. It's so distinctive. And remember, they're not eating sugar. It's not working. It's not being used by the body. And the body's now eating proteins and fats. And the byproduct is ketones. I have seen blood sugars over 1,000. Okay. So excessive hyperglycemia. A multi. An adolescent with a BMI above 95% has been urinating a lot. What tests can you anticipate for this adolescent? What do those things, what could that mean? There's a lot of concepts in that rolled into one. Well, number one, you got to figure out if the urine, there's no infection. That's the first thing you rule out. A BMI of 95% is really high. So we're going to do a hemoglobin A1C. Okay, something's going on there. And because they're urinating a lot, they're losing their potassium, right? So we really need to watch your electrolytes. That was a lot wrapped up into one question. Pregnancy really doesn't have anything to do with that. Diabetic ketoacidosis is caused by what? So diabetic ketoacidosis is caused by no insulin, and we're using protein and fats for energy. Simple. And ketones are poisonous chemicals when they build up. It's not the ketones, it's the metabolic acidosis, which is poisonous to the brain. It's acid going through the body, which is caused by the ketones, okay? And caused by the body not using sugar and burning other types of fuels, okay? Another multi. A child's admitted with a blood sugar greater than 600 has large ketones in the urine. What's your priority first thing to do for these children? So I said they're pale, they're lethargic, they can barely get in the stretcher when they come in. They're dehydrated. First thing is IV normal saline bolus. We're going to be giving them fluids. And then we'll be placing them on a regular insulin drip. It's very slow. And we'll be monitoring extremely closely their insulin. So number one, IV bolus. Number two is the insulin drip. And then we'll be monitoring how is their potassium level, making sure we give it. Sub-Q, nothing at this point. Sub-Q is too slow. We need the insulin to work quick, and that's why it's IV insulin drip. A diabetic child complains of feeling jittery. The blood sugar is 45. What's the best treatment for this child? They're complaining, they're jittery. Their blood sugar is 45. What are you going to do? So they're complaining. That means they're awake and somewhat alert, right? You're going to give them something orally. Orange juice, milk, and then remember they need some proteins after that, like a turkey sandwich would be great for them. The turkey, the protein would be good. So when you're looking at questions regarding blood sugars and a child, remember, are they awake or are they unconscious? Now, if they're unconscious, we're going to be doing something different, right? Give glucagon. Give something IV, D50 IV. But when they aren't, you're going to be, when they're awake, give them something orally. Why not? Your patient has experienced a head injury. What would concern you the most? Remember, head injury, swelling in the brain. What do you be worried about there? Decreasing urinary output absolutely has to do with the pituitary gland in there, right? Being squished because all of that pressure. What might you give if it's due to fluid? Mannitol, right? So now we've put the whole story together. A multi. How do you detect diabetic ketoacidosis? Well, number one thing that you would do, absolutely, there's ketones in the urine. That's the first thing that we would do. And then, of course, you're going to see the elevated blood sugars and the 4+ glucose in the urine. But knowing that there's ketones, absolutely, it's when we do the dip and we see ketones. A multi-select. What would alert you that a child's head injury is deteriorating? They're out there, they hit their head, they were in a car accident, they fell off a balcony, they playing sports, their knee in a crack and they were unconscious. Now what are you going to see? Well, they're getting more and more and more confused. They are getting now difficult to wake up. They're going to sleep on you. And because all of the pressure in the brain, lack of oxygen, they're getting restless. And one of the things is the headache is getting worse. And one more thing that you'll see is vomiting unrelated to eating. And children, you see that vomiting more than you see it in adults. So children vomiting, head injury, that's a big red flag. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? Bacterial meningitis. We have viral and we have bacterial. They're both treated differently. Viral is symptomatic. Bacterial, what do you do? And it's antibiotics are your priority. Now, viral is strict INO, daily weights, of course, but it's going to be acetaminophen, ibuprofen to monitor that fever and pain. And it's also going to be bed rest and, fluids, but monitoring how much fluids because of the fever, okay? But in bacterial, we know there's something that caused it. we're going to be doing antibiotics. And we know if we have bacterial meningitis, we've already done a spinal tap and we have seen white cells in it. And we know that it is bacterial. What is the primary cause of injury associated with submersion or drowning? Now, I live in South Florida. I've seen quite a few drownings in my life. I've seen good outcomes and I've seen not so good outcomes. What happens when you drown? And some kids come up, vomit, and they're fine. And we think they're okay. Well, it's all has to do with fluid in the lungs and oxygen not getting to the body. That is the primary cause of injury. Now, because of that, this is the child that's more at risk for respiratory distress syndrome. And it can happen up to 72 hours later. These children are admitted, placed on an O2 saturation, and they're monitored closely, usually like a step-down unit. And last question, a multi. What CSF lab results correlate with bacterial meningitis? You get a child in that's showing all the signs of meningitis, the nuchal rigidity, the headaches, the lights bother their eyes, set them up, you're going to go for a spinal tap. If it comes out clear, it is absolutely viral. If it comes out milky or something like that looking, I've seen them look like milk. You're going to see white blood cells too numerous to count. You're going to see low glucose because, bacteria love sugar and it eats it up and it doesn't want protein. So elevated proteins, okay? Will that help you remember that one? See how we did? JLB is number 3. Number 2, Turbo. I used to know a nurse named Turbo. Number 1, Miss Fig. Good job, Miss Fig. This was an easy one. And an ABC and a KKK. And an MOUSC. Anyway, anybody wants to review this exam, anybody who's not done well in the last 2 exams, please, let's make some weekly tutoring. We can get together. I can do them as groups. I can do them one-on-one, whatever works. You guys give me a time and we can do it, okay? I will get you through this course. You only have to ask for it. So any questions?